in individuals with a CAG repeat length longer than 25, they were found to have a higher frequency of hypogonadal symptoms based on the Adams questionnaire, which includes things about energy, libido, some depressive symptoms. And that was even with normal testosterone levels. So testosterone levels in the conversion here would be above 340 nanogram per deciliter. So even in a eugonadal state, and maybe this is 350, which is still kind of a low testosterone level, but normal. That was compared to people who had CAG repeat length less than 22. All right, so now actually getting into the research on the CAG repeats. So sexual function, testosterone replacement therapy. We have a little snippet here. And important to note that some studies show no correlation. So in each of these categories that we sort of go through, it is sort of weak preliminary data. It's not conclusive. 10 years from now, it may be totally different. But in individuals with a CAG repeat length longer than 25, they were found to have a higher frequency of hypogonadal symptoms based on the Adams questionnaire, which includes things about energy, libido, some depressive symptoms. And that was even with normal testosterone levels. So testosterone levels in the conversion here would be above 340 nanogram per deciliter. So even in a eugonadal state, and maybe this is 350, which is still kind of a low testosterone level, but normal. That was compared to people who had CAG repeat length less than 22. Yep. And the average CAG repeat length, let's just kind of peg it at 20, just so people can keep that in mind. So if 100 people go get them, maybe it's 20, 21. Varies based on ethnicity, but you kind of think of, okay, 25 is well above average. If somebody is at 16, they're well below average, more sensitive to androgens.
Yeah, and this is hard to track over time, but a lot of CAG repeats, or in general, a lot of trinucleotide repeat conditions, the pathologic condition in this case would be Kennedy's disease or spinal bulbar muscular atrophy, which there's like partial and full. So partial could be 35 or 40. So there's different cutoffs for that. But a lot of these conditions tend to increase over time. One of the theories that could potentially be happening, not necessarily related to the study, is that over time, as there's way too many world wars and way too many unnecessary deaths of even teenagers, people that volunteer at least, or people that are drafted and then go to the front lines, perhaps they have a lot of that androgen activity in the amygdala and in the prefrontal cortex, and they die before they reproduce. So perhaps the average number of repeats is increasing, kind of hard to say. One of the potential, I guess, negative feedback mechanisms is if you pass it on to a female and she has PCOS and anovulatory cycles and reproduces less, which with modern technology, I don't think would be the case. But perhaps 100, 200, 300 years ago, these females with PCOS would ovulate less. Perhaps they'd have other secondary sexual characteristics that are more virilized and reproduce less that way via natural selection. That's not really happening as much. So perhaps these are balancing out more now, but it's kind of hard to say. That's more sociology. We're not sociologists. Go see your family sociologist for official advice on that. Regarding the takeaway from this specific study, if your total testosterone is above 340 and you have symptoms of low testosterone, perhaps it's due to a less sensitive androgen receptor, but perhaps it's due to dopamine, perhaps it's due to low estrogen, perhaps it's due to other neurotransmitter hormones.
Yeah, there's a lot of other factors to look at before jumping straight to testosterone as a root cause, which it can be in some cases, but not every case.
Yep. We just make sure everybody's total T is at least 1,000 before considering other causes.
Yeah, and then looking at the effects of actual testosterone replacement. So let's say one of these guys does come in, they have the positive Adams questionnaire, they've got a low testosterone. It looks like the improvements in just specifically sexual function, so erectile function, libido, et cetera, are better in those who have shorter CAG repeat length. So intuitively, this kind of makes sense if you think of short CAG repeat length, more sensitive testosterone, or more sensitive to testosterone. Mm-hmm. Or it could be a sort of a time effect where they realize more of those benefits up front, because we know some of the data on TRT, people will continue to see some improvements all the way out to 12 months. I mean, in terms of how people feel immediately, probably within 3 months, you kind of know, assuming that you have gotten the dose correct, But then things like lean body mass will continue to change. Erectile function can continue to improve all the way out to that 12-month mark.
Let us know how your discussion with your PCP or endocrinologist goes when trying to use this data as explanation for your TRT plus and synthetic androgens. So yeah, just let us know in the comments for that. That'd be great. Interestingly, you would assume that anyone with Kennedy's disease or spinal bulbar muscular atrophy, they probably just, try whatever strong androgen or non-steroidal androgen receptor agonist that they could find, right?
Yeah, you would think intuitively.
No, doesn't appear to be the case.
Yeah, preclinical data. So again, this is Mickey Mouse data. Can we coin that term now?
It is Mickey Mouse data.
It is. It's off patent.
Yep.
Or trademark.
Yep.
So yeah,
it's the official trademark. It's the unofficial official trademark.
The official sponsor
of preclinical
Gillett
data.
Health podcast.
Yeah.
They gave these mice Lupron, and basically it's an androgen or a GnRH antagonist. You're going to see basically no level of circulating sex hormone that's significant, and
it binds the GnRH receptor so strongly that it deactivates it.
Yeah, it breaks the feedback.
Yeah, just think of it as
castration.
Yes.
Yeah, in simple terms.
Chemical castration.
So you've got no testosterone, but then muscle weakness improves, or these mice get stronger.
Mm-hmm.
So obviously this is going to cause other problems in humans, but it's interesting to see something that's like, okay, let's take away all the androgens so that the muscles function better. Like it's very counterintuitive. It's a really interesting study there. So, and while we're talking about Kennedy's disease, above 40 repeats is considered pathologic, but even in things like 35, 37 repeats, you still see the disease emerge. It just happens at a later age.
Yeah, that's a good summary. Some of the things we talked about when thinking about like the high CAG repeat phenotype is, could you design the perfect ligand, and would you use a steroidal agonist? Would you use a non-steroidal agonist like a SARM? And also for those individuals, could you design a perfect SARM? Because one of the main reasons why there's not a whole bunch of studies in this patient population with very strong classic synthetic androgens is the side effects.
Yeah, I mean, if you could use another vector, like let's say you do want, in this specific case, you want an antagonist in the muscle because the longer CAG repeat is creating a toxic protein folding that's actually pathologic.
The toxic.
You could have you could have an antagonist in the muscle and then use another vector like something through perhaps myostatin to offset that effect, but you still want to have plenty of androgen signaling or dopamine signaling for things like energy, motivation, libido. So it would be interesting to sort of put together the perfect formula there, the secret formula.
Yep, the secret formula. I'm still hoping and praying that Sustantia turns out to be the perfect SARM, but we still don't know that yet. Just Mickey Mouse data.
Yeah.